tobacco-related lesions.
Welcome, Dr. Nanda.
Thank you, sir.
I'll just give a brief introduction. He's Associate Professor at AIIMS Raipur and has worked previously in AIIMS New Delhi and certain hospitals in the Gulf too. And now we do have our common discussions for these kinds of patients. I think in continuation, this should be the best way forward. Thank you.
Thank you very much, sir. And respected chairpersons, all the dignitaries in the hall. And after two brilliant talks by our director, sir, and Mishra, sir, I think it becomes more difficult on my part to take you through the next topic, which is radiotherapy in tobacco-related lesions. Now, tobacco, as it's been deliberated before also, it's a product that is prepared by curing the tobacco leaves. It belongs to the plant called Nicotiana and Solanaceae family, the nightshade family. More than 70 species are available. And now there are various forms of tobacco which are used all over the world, mainly smoked forms and smokeless forms, as already been told. There are cigarettes, cigars, and BDs. BDs are common in India. They are made in India mostly. They're basically tobacco wrapped in tendu leaves, and they are tied with a red or colored thread at the end. Now, these are the smoking tobacco forms like hookah, which is a double-barreled or single-barreled tube with a glass base, which is used for smoking. It uses the water filtration method to create the smoke. And in pipe, there is a chamber in the front wherein tobacco is burned and smoked through the thin stem or shank, and that ends in a mouthpiece. Now coming to the next one, Cretex, they are normal cigarettes but with flavors of clove and other flavors which are originally from Indonesia, but as you know now they are available everywhere in the world. Now coming to smokeless tobacco, what is smokeless tobacco? It is a tobacco that is not burnt. It's also called chewing tobacco, oral tobacco, spitting tobacco, dip, and many other names. Most people who chew or suck the tobacco in their mouth, they spit out the tobacco juices when they build up. Now chewing tobacco can be of two forms, sweetened strands or shredded forms. The one on the right top corner is the shredded form, and the left one is the sweetened strand. Now there are many things like dipping tobacco and creamy snuffs, which are nothing but pastes of nicotine along with clove oil, glycerin, spearmint, menthol, which are marketed in India mostly to women in the various brand names, and they are also known as misri in some part of the world like Maharashtra and Goa. Now this has already been shown to you in many previous slides by Mr. Sir. Now gutka is very common in India, which is crushed betel nut tobacco, which has sweet and savory flavoring. Now snuff is ground smokeless tobacco product, which is either inhaled or snuffed through the nose. Snus, again a steam cured moist powdered tobacco that is not fermented, and it induces minimal salivation, and it is consumed by placing it against the upper gums. And it is very similar to the dipping tobacco, but the main difference is that it does not create a lot of salivation and doesn't require spitting, and it has significantly lower level of tobacco specific nitrosamines. Now these are new things called e-cigarettes. Many people think these are very healthy, but that's truly not the case. Electronic nicotine delivery systems, these are actually battery operated aerosolizers which have nicotine cartridge, which when switched on can actually produce an aerosol which has mixture of nicotine and some flavors, and it can be smoked. All the types of tobacco that I just mentioned are used in India. Along with that, some of the other varieties like the hookahs, chillums, and dhumti. And we here in India have more of smokeless forms like pan with betel quid with tobacco, pan masala, that's gutka. There are local preparations like manpuri tobacco, mawa khani, and other things. And we have other tobacco products for application like the mishri, gul, bajar. And there is one more thing which is used in India very commonly is the lal dant manjan. That also contains a lot of tobacco. Trends, BD is the #1 smoking form of tobacco in India. Second is cigarettes. Chewing form, pan with tobacco is the most common, followed by dried preparations like gutka and mawa. And the last but not so unimportant is the dentifrice or the lal dant manjan. Now second-hand smoke is the smoke which comes out from burning tobacco products and is the smoke that is breathed out by the smokers. Does it have any problems? Yes, it does cause serious cardiovascular, respiratory and lung disease and lung cancers. More than 600,000 premature deaths are because of this. In 2004, children accounted for 28% of all deaths which were attributed to secondhand smoke. Now, secondhand smoke as per WHO results in 1 in 10 tobacco related deaths worldwide. So, secondhand smoke has been designated as a known carcinogen by all the major world agencies, like these agencies. It causes about 3,400 lung cancer deaths each year amongst adult non-smokers in the US. And as per the Surgeon General's report, the people who live with the smokers, they have a 20 to 30% increase in risk of lung cancers. Now, tobacco is the main cause of preventable premature mortality. It has a particularly profound impact on cancer incidence and mortality. Tobacco is causally associated in many different cancers. I'll come to detail in the next slides. And it accounts for almost 30% of all cancer-related deaths. There are many chemicals which are there in tobacco smoke which can cause cancer. It's already been told to you. Now, are there harmful chemicals in smokeless tobacco too? Yes, because no tobacco in any form is safe. The important ones are tobacco-specific nitrosamines and polonium and PAH, which causes cancer. What is the difference between smokeless versus smoked tobacco and cancer? People who smoke and they vis-a-vis who do not smoke, smokeless tobacco taking people have 3 to 4 times as much nicotine in their blood as smokers. And nicotine stays longer in their body compared to the smokers. They do have all the hazards of smoking compared to smokeless tobacco. And smokeless tobacco is more prone to cause, as already been mentioned by sir, oral cavity and pharyngeal cancers. Now, well, somewhere here we come second, fortunately, to China. We produce around 900,000 tons of tobacco each year. China tops at least 3 times more than us. What are the hard facts? Now, the global tobacco users stand at 1.3 billion, and almost 50%, that is the 6 million people each year, are killed by tobacco. More than 5 million of these deaths are actually directly related to tobacco use, and 600,000 are killed are non-smokers who are being exposed to secondhand smoke. So that is also an important cause of tobacco-related deaths. More than 80% of the nearly 1 billion smokers are in our low and middle income countries. So that's a huge burden on our countries. This very ambitious program, Global Tobacco Surveillance System, started in 1999, and they have produced a global adult tobacco survey atlas which was produced in 2015. According to them, India comes in the second rung of countries where the smoking is as high as 25 to 35% of the population who are 15 years and above. And other data about India is that 48% of males and 20% of females, they use some kind of tobacco in India. 24% of the males and 3% females do smoke in India. And the overwhelming use of smokeless tobacco globally is in India and Bangladesh. Out of them, 266 million people are only in India. So that's a huge burden. Now, as per the state scenario, you can see that Chhattisgarh, along with Odisha, Bihar and Jharkhand, is the main center of tobacco use. That is 45% of or more people of 15 years of age and above use tobacco in any form. And this is also true for some of the northeastern states. Rest of the country, it ranges between 15 to 35% of the cases. Now, this has already been shown by Mishra sir, the same slide. This is a Surgeon General report, but however, I am very surprised that despite mentioning all the cancers, they have nicely missed out the oral cavity cancers, which is probably one of the important cancers related to smoking. Should come here in #1 position on the top. Now, these two cancers, prostate and breast cancer, though there is evidence which is suggestive, but they are not sufficient to be associated with breast cancer, though smoking can increase risk of death from these cancers also. This has already been told what nicotine can do. It can change the cellular environment to proliferate the normal cells and transfer cells into cancer cells. It can have cellular survival pathway modification which lead to prevent the death of mutated cells. It can cause cancer proliferation. new angiogenesis, migration, and invasion. This has already been deliberated previously. Now, to be precise, I will be limiting myself to the role of radiotherapy in malignant lesion or cancer, particularly to the head and neck, because this is not sufficient enough time, or maybe the forum is not ideal to discuss all the cancers in this small time. Now, these are general principles of RT, that RT can kill the tumor cells by direct or indirect effect, which leads to apoptosis or mitotic cell death by cell division. And some of the tumors are very radio responsive, which start to shrink in days, but most of the head and neck cancer take longer to shrink because of this feature, that whenever the cell cycles, only then the cell gets killed. Now, this also have been told by my previous speakers, that early stage, unfortunately, we do get cancers in early stage where people do refuse surgery or they are unfit for surgery. Otherwise, surgery still remains the #1 choice for patients. And if that is not the case, then radiation can be also used in early stages with equally good results. But I would put it in a slightly lower step than surgery, except for conditions like CA larynx, wherein the voice quality preserved is better. Locally advanced, again, combined modality is required. Surgery with post-op concurrent CT-RT is the gold standard. This is used for advanced tumors and poor prognostic factors. And radiotherapy has an important role to play in palliation of the primary as well as for the metastatic disease, like the bone metastasis. These are some of the tumors that we see in our OPD. There's a young man on the left top corner who was smoking. He's just 40 years, looks like 60. He had base of tongue carcinoma with massive nodal disease, and these are other tumors that we face in our OPD. Now, coming to the techniques of radiation, external beam. Previously, we used to have conventional 2D techniques. Nowadays, we have 3D conformal radiotherapy, intensity modulated radiotherapy or IMRT, image guided radiotherapy. These are all conformal forms of radiotherapy. We also have brachytherapy. It has a role to play in the head and neck tumors. Now, as you progress from 2D to 3D to conformal IMRT, what we have done is actually, because of the advent of new radiological modalities like the MRI, CT, and PET scan, we have been able to, diagnose the cases very easily and to know what is the exact volume that we are going to tease and how to separate out the normal tissues from the tumor tissues. These were the fields that were being used probably 2 decades back to treat patients of this. You can see is a CA larynx patient, wherein there's a large field. We do know there is tumor inside, but we don't know where exactly it is. So we are using very broad fields. In the process, there were all the normal tissues which is being irradiated to a very significant dose, and patient used to have a very horrible life afterwards. Now, coming to conformal radiation therapy, I'll try to simplify it. There are 2 types, 3D CRT and intensity modulated radiotherapy. 3D CRT is basically based on the data that we have from CT or MR. We have a geometric field marked on the machine, which will conform to the tumor. Whereas in IMRT, along with the geometric field shaping, there is also modulation of intensity of the beams. If I can describe it like this, that if there is, suppose there is a beam, which will be broken into very small beamlets, like these ones we have here. Well, let me continue. The beamlets, where we can have various intensities on the beams. If you can imagine that probably the white ones will be given 1 mark or weightage 1, then the red one will be given weightage 5. So accordingly, the beam will be stronger somewhere and weaker somewhere, so that the area of the tumor or the gross tumor volume will receive the maximum dose and the minimum dose will be given to the tumors. These are some volume concepts which is given to us by the International Commission of Radiation Units and Measures, which say that these are things which are to be definitely known by the radiation oncologists before they can plan the treatment, wherein the gross tumor volume, the clinical tumor volume, and the planned target volume has to be decided. Now, 3D, as I have told you, 3D CRT requires precise definition of anatomy, and a sophisticated treatment planning system is needed, which can calculate the dose. Just by having a diagnostic modality or having the contouring done, we cannot really execute that plan. we need to have a high-end treatment planning system, and that plan should be deliverable by a machine. So coming to the IMRT is a very advanced form of 3D CRT. It uses non-uniform radiation beam intensities like I just described, maximizes dose delivery to the planned target volume while minimizing dose to the normal tissues outside. You can see a comparison on the right, which shows that IMRT spares the parotid gland very nicely, whereas you can see the conventional plan, which is almost entirely irradiating the tissue. Benefits: better normal tissue sparing, reduced late toxicity, dose escalation. We can even have dose paintings by incorporating the biological modalities, and biological information from PET can be used to boost dose to particular areas which are actually active disease. And we can also use this for re-irradiation where patient has previously received irradiation. Now, image guided radiotherapy is basically IMRT with image guidance. Every day before treatment, pre-treatment imaging is done so that the position of the tumor and the patient is confirmed before we can treat. Because a high-end planning which is being delivered to the patient without confirmation of the patient position is just like you can precisely miss the tumor and not have the treatment in the proper way. Coming to the process or workflow of conformal RT, it is the same for all the conformal RT, whether it be 3D CRT, IMRT or IGRT. Starts with patient immobilization with a mask. This is a thermoplastic device which is used for casting the patient so the patient doesn't move. Then the patient is moved to a CT scanner for data acquisition. The data is transferred to the treatment planning system or TPS, and then we go for the contouring to define the target and the normal tissues. After that is done, the 3D model is generated, and there are two different kind of planning which is followed: forward planning or inverse planning. Inverse for IMRT and forward planning for 3D CRT. Then the dose distribution is analyzed, and if it is accepted, the computer can actually do thousands of iterations before we can reach the final dose which we are satisfied that, well, normal tissues are being saved and the tumor is receiving maximum dose. Then it goes on to the next step, which is treatment quality assurance, followed by the treatment delivery. Now the same process is simulation with mask, CT scanning, wherein we mark the patient with the lasers, and then we do the CT scanning, acquire the data on the TPS and do the planning. This is the image which is showing contouring and normal tissue rendition along with the tumor definition. You can see the spinal cord, the parotids and the mandible which has been marked along with the skin outline of the patient. We can see in all directions, so that's why it's called a three-dimensional thing. Now for very early laryngeal cancers, we can limit the radiation volume or dose just to the larynx as it is shown in the image without giving significant dose to the spinal cord which lies very close to the tumor and to the parotid glands, so that the quality of life of the patient is much better after receiving radiation. Again, a comparison of a nasopharyngeal cancer patient showing that IMRT can actually significantly reduce the dose to the parotids, which is on your right. Another comparison of 2D, 3D and IMRT, you can see that the volume remains the same, whereas the IMRT actually conforms to the target volume very well. This is another image showing a 9-field IMRT plan for nasopharynx, wherein you can see that various beams are placed from various angles and their intensities are all different. You can see dose distribution 70 gray within the blue line, which is the highest dose being planned, to the red volume, which is the volume of interest. And the peripheral red line shows that the dose is very insignificant, just about 50 grays. Now how this is possible? This is possible in the linear accelerator by a device called the multi-leaf collimators. Multi-leaf collimators are basically computer controlled devices which have 120 or more leaves in two banks, which are computerized and move independently. They can move to 40-40 and come down to 2.5 to 5 millimeter in size. No patient movement is required, and the movement is continuous along with the movement of the machine gantry. This is how the MLC changes position in different gantry positions. This is a small video about the MLC, and it shows that how the leaves are moving automatically once the plan is executed. It's all computer controlled, so they start moving and they cross the midline also if required, and by moving from one place to another, they actually generate the intensity map which I showed you. so that some areas receive less dose and some areas would receive more dose. Now coming to brachytherapy, this can be either interstitial or intracavitary. Brachus is a word which comes from the Greek word meaning short. Brachytherapy is a form of internal treatment, radiation treatment, which is where a radiation source is placed either on the tumor or inside the lumen of the tumor or into the cancer tissues. Common types are LDR, the low dose rate and high dose rate. HDR is very frequently used in head and neck carcinomas. Now, this is a technically advanced form of brachytherapy. It has a single high intensity iridium source of 10 curie strength, and this is delivered with minimal millimeter precision under computer control, with less dose irradiation to the normal tissues as well as to personals who are using the machine. Now, this is a sample case of lip cancer wherein the tumor is being marked, and after that still needles are being placed through and through the tumor, and then we put the brachytherapy tubes which basically pass through the steel tubes, and steel tubes are removed and they are secured by buttons, and once they are secured they are attached to the machine, HDR machine, and the treatment is delivered in various fractionations. Now I'll show a small video before I end about how external beam radiation is actually given. This is a linear accelerator which is showing different stages of planning the treatment, wherein the patient comes into the room, he is lying down, and he then mask is put on his head and upper part of the shoulder so that he doesn't move, he is fixed. Then the position of the table is raised and fixed in a position wherein he can actually be matched to the position which has been done during the simulation. These are the laser lights, you can see green lasers on the sides. Now once that is done, the patient is in position and the patient is getting ready for the imaging. You can see two robotic arms, one on the top and one on the bottom, which will open up and they will start taking the image of the patient. This is basically an IGRT process because IGRT is an extension of IMRT. These are robotic arms. The upper part of the robotic arm is basically a KV imager and this is a detector. They are basically positioning automatically on the patient and they are taking the image.